This meeting is being recorded.
Give me a couple minutes. I'm in journal.
Camera. All right. Perfect. First patient of the day? Yeah, first patient.
Hello. Sorry about the delay, my people. Sorry about the delay.
Good morning.
Excellent. Good morning.
Good morning.
Excellent. Great to see you guys. Oh, well, sorry about the slight delay. I hope you guys are doing great. Let me know if you can see the presentation. Just give me some love, some thumbs up or whatever you want to do. That would be greatly appreciated. You see it there? I saw you see it. For those of you online, before I start, because once I start, I'm not going to be able to come back. Can you see a picture that says clinical case?
Yep.
All right. Thank you. Thank you, Sarah, for stepping it up and participating. I appreciate it.
You're welcome.
All right. Let me present you a case. This is a case that has a significant amount of veterinarians involved and definitely would have not been possible without the collaboration of all of them, Colton, Ramstrong, and even Pendleton and Dr. Lugo from Ocalaequine also helped out. So this is a self-safe filly that is a 2-year-old and was presented for show. She's supposed to be a show horse, and she presented because she was acutely lame in September 2024. 4 out of 5 lame. She was very sensitive to the hoof tester on the toe area, and she was suspected to have an abscess, right? So she was proper. Hey. Ah, shit. I'm sorry. Okay, all right. No, that's fine. Sorry, we're doing some magna wave here and got me distracted for a little bit, but I'll get used to it. You can keep going. So she presented like this. And for those of you who cannot see over there, well, she is walking very stiff. And she just have a lot of reluctancy to work. This video was given to me by Santiago and Camila from when she arrived. So for those of you on the other side of the screen, she just has a very weird stance. She doesn't want to walk forward. She doesn't want to put weight on that leg, but she doesn't feel like she wants to put a lot of weight. Then the soft-right boots were put to see if it alleviates the pressure. And she still didn't really do a whole lot of improvement with the soft right, which was kind of weird. So everybody suspected an abscess, obviously. I think that is one of the main differential diagnoses, and sure, there's the evidence of it. So here we see that there is a someone's trying to log in. Good Lord, I don't know if they come later through. So if you can see around here if you can see in the toe, there's obviously a radiolucent area, right? And if you can see, I'm gonna put a little thing here. Right, we can see right here, there's a little bit of a radiolucent area. Other than that, in this radiograph, we show a very slight remodeling on the distal P2, and not a whole lot. I mean, we can get very technical about it, but not a whole lot that could explain the degree of lameness that is going on with her. Now, if you see in the dorsal-ventral view, and this might be subtle, but it's going to become important later on in the resolution of the case. But if you see in this radiograph on the dorsal P3, she has a little bit of a loosened area right there. So hold that thought and keep that in the back of your head. So far what we have a horse that is presented on September 20. She's 4 out of 5 lame, sensitive to the hoof tester. Obviously, she has an abscess. And then we started treating her like an abscess, saltwater spa, poultice. Dr. Licho, I believe, put her on pentoxifylline for prevention of laminitis on the other leg or increasing blood flow, because the horse was a kind of a confusing case. Then, after several consults, evaluation, and scared because we had no idea what was going on, this horse, we ended up doing a low 4-point and a venogram. And this is a venogram. On the picture of the left is on the early stage of the venogram. On the picture of the right is on the later stage of the venogram. Now, one thing that I want to show you is that in this venogram over here, there seems to be lack of blood flow on the toe, right? So that could be an indication of a poor technique, that I haven't put enough contrast, or it could be an indication of some sort of pathology, right? So what we ended up doing is we lifted the leg a little bit and we let the contrast sink in. We let the contrast disperse a little bit more. And here is when we see in the picture of the right, we can see that there is some blood flow on the toe, of course. So that's important to talk on the discussion of this horse as well when we talk about the resolution. But regardless, that caught our attention. This is the dorsoventral view and the dorsoposterior view of the venogram. Not a whole lot, except that here we can see, if we carefully look, we can see the area of lysis of the radiolucent area. Nothing super mega diagnostic. So on September 23, the horse continued to be 4 out of 5 lame and with a low 4-point block, and we repeat regional imperfusion with imipenem. Why did we do this? Because now we're starting to get concerned. Hey, is this a regular abscess, or does she actually has a bone infection as well? Reason being that the abscess has bursted out. So usually when the problem is only an abscess, they tend to get a lot better right away, right? In addition to that, I think I'm going to go backwards a little bit, but we also did a CT scan on her because we were extremely concerned that this horse continue not to get better. And I'm going to show you a picture of the CT scan later on. But we continue doing the regional limb perfusion, and this is how she looked like after the regional limb perfusion. This is September 2025. So she actually started walking better. And I'll play this again for your sun glare, Dr. De Angel, so you can see it better. So she actually started walking better. Now, please excuse me on the out of a series of where the CT scan pictures are coming, because we did the CT scan before that video, okay? But we did ended up doing a CT scan because we were just not convinced that this was a regular abscess, and we were not convinced that this was a regular bone infection. Now, if I missed something, let me know, because I just did that. Good. So here in the picture on the right, this is the CT scan, and the arrow is showing to an interesting area of where there is lysis or infection in that bone. But interestingly, on the picture on the right, we could see that this horse also has a bone cyst in the P3 bone. So there's a bone cyst in the coffin joint area, and this bone cyst was not present, appreciated in the radiograph. In addition to that, the CT scan did confirm that this bone cyst was articular. So now here we are. We have a mess of a case that is 4 out of 5 lame, was not getting much better. We have some sort of bone reaction or bone remodeling, whatever it is, and we have a bone cyst. So the question to us is, okay, what do we do? How do we know which one is causing the problem? Why is this horse so lame? Why did the abscess burst out, but she continues to be so lame? So we had several options, and we talked to the owner extensively about this because it was truly confusion. We ended up involving 2 other specialists in the case, plus us over here, and we were confused, right? Then the question came, let's block the coffin joint. And we say no. So we didn't want to block the coffin joint because there was an abscess going on and there was an infectious situation going on. So we didn't want to go through that risk of putting a bacteria in the coffin joint. So we could keep going with the regional limb perfusion of imipenem. We could do nothing. We could treat the cyst at this moment, or we could go to surgery and scrape that bone and find out what's going on with that bone. The owner, thankfully, was a veterinarian. She was very accommodating, and she said, what are the options that if the antibiotic fixes this problem for now, what are the options that we're going to be on the same space 3 months from now? So I said, I don't know. So she opted for surgery. And this is how she walked right before surgery. So this is after several regional limb perfusions. Camila told me 4. After 4 regional limb perfusions with imipenem. So obviously we are taking care of the problem, but we still decided to go to surgery, and we go directly on where the CT scan is. And we decided to open up the hoof, and this is us in the surgery room, in the table, getting the hoof open. And we use a little bit of intraop radiograph to tell us exactly where to go and where to open up. But I want to show you something super interesting that came up on the radiograph, and I don't know if you can appreciate it on your end, but in the lateral view over here, you can see where we did the resection. There's actually a radiolucent area right here above the resection. And in addition, you can see a track going up, all the way up, right there to the coronary band. So that really calls our attention. And when we put the probe from here up, we found this soft spot. So what we decided to do at that moment was to make the resection bigger and go then all the way up. This is what it looked like on the dorsoventral view, and this is what it looked like after the full resection was done. So the interesting thing is that we ended up finding a very, whoa, we ended up finding a very nice keratoma. We ended up finding a very, very nice keratoma, and the picture does not make, the picture is kind of bloody, but it's right here. You can see a nice defined keratoma, and it's very interesting because you don't always get them to be that nicely undefined when you escape them from surgery after you have done several of these. Sometimes you notice that they just come up in the resection. So in conclusion, we actually did have a keratoma and we removed it surgically. This is how she looked like right after surgery. So not much difference to, to before surgery, right? Because she was already very sound before surgery. Definitely much more willingness to walk, much happier horse. And here's how she looked like the day after surgery, just for you guys to know what the wound is going to look like the day after. It looks like a nice hole in the hoof, granulates very quickly. And what we ended up doing, for those of you wondering how did we cover that hole, we prepare a mix of metronidazole and gentamicin. So we mix and we have a very, very specific recipe that we have been using for years, which is very, very precise. We just put enough metronidazole with enough gentamicin to make it a paste, and that works great. And here is the final bandage. Good. So that was the case, and she came 20 days post-surgery, i.e. yesterday, and she is walking like this. So she's still walking in 4 legs. She's still looking pretty good. And we're very happy with the progress. Now I'm going to show you some follow-up radiograph on how she is doing radiographically. These are the radiographs from yesterday. You can see on the left-hand side, there's things, there are some lucencies around, but the bone's still looking pretty good. You can see on the right picture, you can see where the keratoma and the area of surgery was. And sorry, the shoe will take off some of the images for you, but if at the end of the discussion we still have time and you want to see any of this again, we can give it another shot. So we decided she's at home. She went home with some antibiotics, a little bit of enrofloxacin, but probably to discontinue shortly. Is she still on Doxy?
She's on Enro.
I mean Enro, I'm sorry. So a little bit of enrofloxacin and at home, some pentoxifylline, and a little bit of bute for discomfort, but then we'll decrease the bute. Then she prognosis is excellent. This horse should do pretty good. Now, let's discuss a little bit about this horse, because now we know that we have a bone cyst to manage, and the horse is supposed to be a show horse. That is the idea. So we need to start thinking about, hey, how are we going to manage that bone cyst? That's for another journal club, but just keep it in mind. Why did we choose the approach that we chose? We all know that when a horse is 4 out of 5 lame, 5 out of 5 lame, there are very few things that could cause that lameness, right? Either it's a fracture, or it's a tendon or ligament tear, or it's an abscess. Those are the three most common causes to have a 4 out of 5, a 5 out of 5 lameness. Even if it's an acute lameness overnight, we still have to consider those. Why did we do the CT scan so quickly? Reason we did the CT scan so quickly and we didn't wait, like a typical abscess, sometimes we wait 2 weeks, 10 days, 2 weeks, 3 weeks before we go to more advanced imaging. But the reason we did that was because the abscess was supposed to be burst out. She had already opened up an abscess and it didn't behave typical at all. The horse was very atypical for an abscess, which that makes the idea of an abscess a little bit more complicated, because good Lord, sometimes I hate these abscesses. You don't know when you're having an abscess. Hey, is it gonna go into the bone? Is it gonna go into the joint? We actually had an abscess that went into the joint once. So they get very complicated, and if we have the advanced imaging, it's definitely highly useful. A bit pricey, but highly useful. I realize not everybody will have it, and nothing wrong with it. We'll discuss the paper a little bit later. Now, let me, and what is the keratoma? Just a quick touch on a keratoma. It's a benign tumor that comes from the keratin producing epidermal cells of the coronary band. So it's a benign tumor. It causes a lot of pressure and some resorption in the bone. That's why it's so freaking painful. So I found this article. In the next 10 minutes, we're going to talk about this article because it's a very interesting article. And I'm going to warn you right now, it's a very bad article, but I will discuss it because there's such an importance to be able to read the literature with critical thinking. Read it with your experience and always question it. Now, the I shouldn't say it's a bad article, I'm sorry. I meant to say it has a lot of room for opportunity for improvement. But they did something very out of the box and very cool. So they PRP combined with polylactic acid 3D mesh to fill the area of resection, right? So that's why it's called platelet-rich plasma combined with sterile 3D polylactic acid scaffold for post-operative management of complete whole floor resection of keratoma in 4 horses. Super cool, great idea. The premises was that the only treatment for keratoma removal is resection. We know that. But they were saying, hey, some horses in the literature, it presents that some horses take 6 months, some horses might take 36 months to come back to performance. They were like, okay, I know that the PRP has growth factors, so it has to help somehow. I like that. There were 4 cases presented. Case 1 was an 8-year-old Criollo gelding from Argentina that had a 12 months draining. 12 months draining. Can you imagine? So this horse had an abscess that didn't resolve for 12 months. 3 out of 5 lame, and this was in the left hind. Case number 2 is a 10-year-old Frisian gelding, 12-month history of draining tract from the subsolar area, and this horse was 3 out of 5 lame also on the right hind. Case number 3 was a 17-year-old Frisian mare with 8-month history of draining tract, and it was a right front. And then the case number 4 was a 9-year-old quarter horse gelding with 3 months history of abscess, no access, and 4 out of 5 lame left front. And this horse did have surgery, it just didn't respond properly. All of the cases presented had showed typical keratoma radiographic finding, and before surgery they put a wooden shoe to help support the foot and quote unquote prevent laminitis. All surgeries were done standing, and then they prepared PRP with a double centrifugation technique. I show you what did they use? They used the Falcon centrifuge tube, and I had no idea what a Falcon centrifuge tube is, so I looked it up in Google, and this is what it looks like. So, just a side note: if you don't understand something in a paper, look it up. So they use the Falcon centrifuge tubes. They spin it twice, spin it one, spin it twice, remove the buffy coat and the platelets, and then they prepare a gel, a polylactic acid scaffold in a 3D printing. And again, I had no idea what the hell that means. So I GTS, Googled that shit. And this is what it looks like. This is pretty cool. So they created a 3D printer, creates a scaffold like this, and then they put PRP in it, all right? And they patch it. So that's a pretty cool high-end device, similar to what we're doing with the gauze and the metronidazole, but now with a 3D printer. So I suspected they printed the gauze. Super cool. This was a very, very cool procedure that they did for these horses. And then they apply these at day 3, day 6, day 9, day 12, day 15, and day 18. They did this procedure. So there was a lot of printing. They had a printing press of PRP. So a lot of printing, actually, a lot of PRP gels were done, and then they applied them arbitrarily. How did they choose these dates? Was arbitrarily, of course, because this is, no one has done it before, right? So they came up with the idea of 3, 6, 9, 12, 15, and 18. So the outcome, they had a great healthy granulation tissue. All horses stay in the hospital 24 to 30 days, and the hoof will fill within 8 months post-surgery. And all horses return to full athletic performance. Excellent. Success. So, to discuss a little bit about this paper, the cool thing that I like about the paper is that they were really interested in printing. They were really interested in thinking outside the box, right? And I really like that. I really appreciate that they were saying, okay, how can we make this better? How can we make these surgeries a lot better? So that was super cool. One thing that I would have liked to see, they did 4 horses. Well, it would have been super cool if they did 4 horses the regular way or the traditional way, 2 horses traditional, and then 2 horses with the PRP. Then they would have had the same control. That would have been nice as well. Actually, it would have been ideal. Another thing it would have been cool is obviously if they have more horses, but that's very difficult because keratomas, they're not that common. But that would have been also cool. And even when they reach their conclusion, their own conclusion, they realize that they cannot attribute the fast growth to the PRP, which is pretty cool because I really think that they went deep and honest into their own research, and they concluded the proper thing, right? Because in our experience here, we don't do that many keratomas, but I think that in the last year we have done 2 maybe, and within 6 to 8 months you pretty much get them all to grow and back to full athletic performance. Anyway, that paper is the coolness about that paper is that they really thought outside the box. They brought really cool technology with the printing scaffold and the PRP, and I'm gonna open it up for questions because we're about to run out of time, and I thought it was a cool case. Questions. And every doctor that work on the case is in the room, so you get to ask him personally.
Panel discussion today.
Huh?
A panel discussion.
Yeah, it's a panel discussion.
So I'm surprised it was not seen in the regional, no, in the vinogram.
I know, right? Yeah, this horse. This was a very, very complicated case to make the decision. Let me tell you, we could not bring any more opinions on this horse because we couldn't find any more bets to ask. Well, that's what I'm saying. Vinogram coming up right here. Yeah, yeah. But let me tell you, from doing the vinogram, I can tell you that it didn't feel right. So after doing many vinograms, you know when to expect that blood to be at the tip of the toe, when to expect the volume, and that blood just was not coming, was not showing up. And after seeing that surgery, then we realized why. But yeah, it didn't show as pretty as it should have.
You didn't see anything there.
Yeah, yeah. Cool.
Interesting that it also improved with the regional lymph perfusion.
Yes, right. And then the improvement in the regional imperfusion was also confusing. But remember that when you have a keratoma, you could have a keratoma for many years and cause no problem. Now, once you start getting a draining tract, that's when you see the problem. And typically, you see a keratoma like this. The horse goes lame. They soak it. They gets better. They go back to work. Then they get another draining tract. They soak it. They get better. They go to work. Then it keeps getting abscesses in the same leg. And then you start suspecting, hey, there could be something going on over here. So that's usually the more typical keratoma presentation. In this particular case, the horse came to us right away, and I think that the reason the reason we found it was more because we were very concerned on the type of lameness, how she was placing the leg, how was she not responding to the soaking, and then responding to the regional imperfusion suggests some sort of deeper infection. I thought she had an infection in the bone. She could have. We scrape it out in surgery. And we did not culture it in surgery. That was our bad.
Did you run histopath?
We should have cultured it in surgery.
No, we didn't do histopath. We still have the sample sitting in formalin next door though. So we could.
No, I'm not. It's so beautiful. I'm not gonna send it to histopath. I'm not. It's so beautiful.
You need to hire an internal medicine now, an internal medicine guy right away.
Yeah, absolutely. It's gonna stay. This is the first keratoma that I get to remove almost completely. So I'm not going to histopath. It's gonna stay here for the record.
Make a necklace out of it.
Yes.
Yeah.
Yeah, just thinking about the improvement from the regional lymph perfusion. Obviously, we have an abscess, we have a resultant lesion P3, there's some level of infection that's probably got to the bone, causing some of that pain lameness. The other thing is we obviously have a vascular stasis, there's a issue in blood flow there, so potentially just putting the tourniquet on there, altering the hemodynamics of the foot could potentially change some blood flow, get blood flow to places that you didn't have blood flow, or at least increase blood flow to the tip of P3.
That's a very good point. Did you guys hear that? So what the consultants say is that obviously we do have we do have some blood flow issues. It's guaranteed, right? Because that blood just was not flowing, period, properly. And then after you put the tourniquet, you increase the blood flow through the foot. So he's wondering, hey, if there is any hemodynamic situation that happened after we put the tourniquet and we pressurize that and pressurize those vessels that actually made the horse feel more comfortable. That's a very interesting point. Whether it's a what kind of circulatory problem is the horse having that we could have improved after putting a tourniquet and pressurizing the blood vessels. Cool. Mm-hmm. Mm-hmm. Cool question / theory. Hey, Dr. DeAngel, I think 2 of your employees were trying to get in, but I just don't know how to get people in once we start. But we encourage
Yeah,
them.
I send them the invitation.
I just don't know how to get them in after we start without stopping the whole procedure. And this case was just a trouble for me since last night, so I just decided to keep going. Let them know that at
Next
7.
time.
Yeah, 6:59. We get everybody in.
All right.
Sorry about
Super.
that.
Not a problem.
Well, and you recorded the session. They could probably see it later.
I did record the session. Yep, you're correct. I'll send it to you. Cool. All right, kiddos. If we have no questions, thank you for participating. And remember, every abscess, if it doesn't solve in 3 days, do a CT scan.
Think about your histopath if you want to present this in your
Journal club.
no, for your how you call it, your certification, your ISELF
Oh
certification.
no,
You might need that histopath. Think about it.
it doesn't have ultrasound. See you guys. We gotta go. We have meeting. Bye bye.
Bye.
Holy shit, we got involved. Oh, yeah.
En la gris. También, en el gris.
here, and we can X-ray the horse with you here. Pues, this is what okay,
Camila study day.
okay,
I don't need Debian at all.
okay.
It's talking and so whatever you need it for,
Huh?
it's free.
So we can do the citations here. or-
Which one are you gonna do?